Welcome to the Parkinson's Solutions Summit 2.0. I'm your host, Dr. Ken Charlin. Today, I have Dr. Dale Bredesen with me. Many of you may have heard Dr. Bredesen's name. He's associated with the Bredesen Protocol for reversal, as well as prevention of Alzheimer's disease. Dr. Bredesen has influenced me greatly. He's trained many providers in his approach. There are many certified Bredesen practitioners all around the world now. And so I'm really looking forward to diving into understanding not just the Bredesen protocol, but how this can apply to other neurodegenerative disorders, particularly Parkinson's, and a big part of our discussion today, Lewy body disease or Lewy body dementia, which overlaps tremendously with Parkinson's. So without further ado, Dr. Dale Bredesen, welcome to the Parkinson's Solutions Summit.
Thanks so much, Ken. Always great to talk to you.
Well, it's great to have another neurologist on the summit, and we can kind of talk colleague to colleague and really dive into things. And we're going to talk about some fairly complex stuff today. So I want to make sure we don't lose anybody. And I wonder if we can just sort of start with the real basics about throwing this Lewy body diagnosis or Lewy body disease into that broader spectrum of neurodegenerative Parkinsonism, and what's the similarity, what's the difference, how do we make these different types of diagnoses?
Yeah, that's such a great point. And you know, with what's going on politically right now, of course, we're all hearing a lot about Parkinson's disease, about Lewy body disease, about cognitive changes, and things like that. And you know, just to start with a 30,000-foot view, as you know, we spent 30 years in the laboratory looking at what is the nature of the neurodegenerative process for all these things: frontotemporal dementia, Lewy body, Alzheimer's. What is that? We understand something about what happens with cancer. You have somatic mutations. You ultimately have more cell growth and survival than you have cell death, and that's what gives you cancer. But the idea of neurodegeneration, as you know, people have said it's about free radicals. It's about, it's about mitochondrial damage. It's about amyloid. It's about tau. It's about misfolded proteins. It's about aggregated proteins. It's about prions. You know, there are dozens of ideas, but there hasn't been one approach to say, this is the fundamental nature of what happens with neurodegeneration, telling us how to treat it, how to prevent it. Just as you've been doing, you've obviously written a whole book about this. So what we found in the lab is that when you look at a neurodegenerative condition, two things happen. First of all, you have to consider evolution. And so what happened with evolution, just as we selected for performance over durability, which is what is associated with our aging, it's called antagonistic pleiotropy. As species evolve, they continually select for performance over durability because, of course, you're struggling against the rest of the world to try to get your food, beat your enemies, all that stuff. Now, when you do that, you end up with great performance. And so we have tremendous cognitive performance, tremendous motor performance, tremendous motor control. And you can, measure these and show how incredible this is. But at each one of these, we have such fine tuning that unfortunately we are over time susceptible to damage, loss from things we're exposed to. So what we found is that for each of these neural subsystems, there's one for plasticity, which goes awry in Alzheimer's. There's one for motor modulation, which, as you know, dramatically needs mitochondrial complex 1. That's what goes awry in Parkinson's. And there's one for motor power, which goes awry in ALS. In all of these cases, there's a whole set of things for supply. There's a whole set of things for demand. So when your supply goes down, which happens as we age with fewer hormones, fewer nutrients, more inflammation, et cetera, your demand goes up, and that's due to toxicity, inflammation, things like that, you end up with a system that's impossible. You cannot support that very complex system. And so the system now begins to involute. You can support a smaller system. And so when you and I treat these and all the many people who are doing this now and getting very nice results, really the first of seeing that you can actually make people better, you've got to reduce that demand, reduce the inflammation, reduce the toxicity, and you've got to increase the supply. So that's the fairly simple overall concept. Now, as you said, now we have to adapt it for each disease. And
Mm,
right, that with Parkinson's and Lewy body, I always think, and you're really an expert in this area, but I always think the paper that showed years ago, if you start with cognitive change and then you get some motor change, it's very likely to be Lewy body. If you
mm,
start with the motor change and then you get some cognitive change down the road, it's more likely Parkinson's and dementia. So I
and
always try to
dementia.
look at, when did the cognitive change, if any, start? And then, as you know, there are the three major, upstream before you ever get the motor changes. People often get those three. They get some anosmia, so they're having trouble with their smell. They get some REM behavioral disturbance, so they may be flinging their arms around, and they often get some constipation. And
Mm.
I was actually surprised to see that just in these large epidemiological studies, you just take the people who had histories of constipation, they are at increased risk
Oh yeah.
for a down the line diagnosis of Parkinson's. So I think that's kind of the typical way, as you pointed out. There's Parkinsonism in both of these, and also in that other third synucleinopathy where you have more the autonomic problems,
Mm.
so-called MSA. So I try to look is this mostly a cognitive thing? Is this mostly a motor thing? Is this mostly an autonomic thing?
Absolutely. And I know it's the old expression, are you a lumper, are you a splitter? And now the
Right.
question is Parkinson's dementia really just another expression of Lewy body disease? And are they really more or less one and the same disease in the long run? You and I, before we started hit the record button, we were having a discussion about what are called biological markers or
Mhm.
biomarkers. And with all of the new emerging technologies to amplify proteins and really look at what's happening at the cellular level and be able to get a simple blood test or other lab measurements, whether it's saliva, stool, spinal fluid, ideally go for the simplest thing to access. Even you brought up had brought up a sweat test, will be much more precise in being able to make a diagnosis. But I wonder, how this will all play out, that this sort of precision medicine will also allow us to choose treatments that are also personalized as well.
Yeah, that's a great point. And I do think, there's a push for, omics, and for looking, and especially with all the AI that's about now, for looking at larger data sets and some really exciting things. And one example that you and I discussed earlier, again, before you started recording here, was that you look at just sweat from someone with Parkinson's. The finding has been that there are 400 different chemicals that they're finding that is as a signature in people with Parkinson's disease. And this, of course, came from a nurse who could smell Parkinson's and said,
Mm,
there's something there. And she was extremely accurate in the blind test that they gave her. And it turned out that you could then look at this with mass spec. So I look forward to the day, I hope it's not going to be too far in the future, where this will be something that, again, you can do with a quick test, and that you can do years ahead of symptoms. Say, aha, here's a person, just like you would say, here's someone with pre-diabetes. Let's make sure they never get to diabetes. If we can pick up many, many people with pre-Parkinson's, pre-Alzheimer's, that sort of thing, and make sure that they never have significant symptoms, that will be a huge step forward in an area where, as you know, the neurology has been the area where there
mm,
hasn't been a lot of treatment. And I would say Parkinson's would be one of the few exceptions where you could actually make a difference in the symptoms, but really not much in the course of the disease. So I think we're in a very exciting time where there are going to be newer, better biomarkers, earlier biomarkers, and more addressable biomarkers. And I would add one other thing, which is very
mm,
exciting to me. I think you mentioned lumpers and splitters. And I think that we have these different syndromes that are pretty clearly demarcated. So,
mm,
posterior cortical atrophy, PCA, which is interesting. It's another one that is an Alzheimer one, but it's closely related to Lewy body disease.
Yeah.
Primary progressive aphasia, PPA, corticobasal degeneration, which is really a Parkinson's-like syndrome, which is a tauopathy instead of a synucleinopathy. But 25% of those people have Alzheimer's disease, as it turns out. And some of these ones that are clearly demarcated. And so then to take those and say, okay, let's look carefully at the omics of those and see, can we find some? And as an example, we had someone, and I would put Lewy body in there as well because it's a pretty demarcated illness. Someone recently cared for by Carrie Rutland, who's a superb health coach out of New York, who has posterior cortical atrophy. And actually, she's doing quite well and has improved and reading again, using the computer again, navigating again. So it's wonderful to see dramatic improvements in her MRI. And if you look at, okay, what were her drivers? In her case, she ended up having Bartonella, a tick-borne illness, which was treated. She ended up having mycotoxins as well. And then she had some metabolic changes as well. So now the question is it going to turn out that many people with PCA have this sort of profile? We don't know yet. But at least it begins to get, okay, can we look upstream at what are these things that are driving this, as opposed to just, we've inherited what came from the 19th century, which was the era of neuropathology, so many advances of neuropathology, and what ultimately became, in the 20th century, synucleinopathies, tauopathies, amyloid-related tauopathies. Now we can begin to say, okay, let's take the next step. How did you actually get this? And I think what's fascinating to me, we've all blamed, as a field of neurologists, we've gone through the period where we blame the disease on the amyloid. And I think now we're taking that next step. Although I know some people are just hanging on to that tenaciously, because yes, it does have some impact on brain function. But the real question is, what brought out the amyloid? It's clear it's an antimicrobial peptide. What brought out the synuclein, which is another antimicrobial peptide? What brought out the tau? Also an antimicrobial protein in this case. So each of these is a response to insults. And I think functional medicine is the best equipped to look at what are those insults that are driving you down these different pathways. And you mentioned earlier that more than half the people with Alzheimer's, also, if you stain for Lewy bodies, synuclein, you can see the Lewy bodies. And I remember the late John Trojanowski, such an absolutely fantastic neuropathologist, who pointed out in a meeting, several years ago, that if they looked at all in people who were diagnosed with Alzheimer's, most of them had all four. They had amyloid staining positive, they had tau staining positive, they had synuclein staining positive, and they had TDP43, which we associate with frontotemporal dementia and ALS, positive. So this makes some sense if we understand that we are responding to these various insults. And then we can identify those and address those. And we can look at what's the profile? Why do some people go down the Lewy body pathway? Some people go down the Parkinson's pathway. Some people down the Alzheimer's pathway.
Oh, no doubt about it. I'll tell you, this is very anecdotal, but we were here at Charlotte Health Research. We were part of the Trailblazer ALS 2 study that put recently approved donanemab on the map. Now, approved, but there still has to be an NDA for coverage. But nevertheless, we're a large enrolling site. And this, folks, is one of the anti-amyloid therapies recently approved for Alzheimer's. The other one is Leqembi or lecanemab. But in order to put individuals into the trial, these were double-blind, randomized, placebo-controlled trials. So we didn't, of course, know who is on treatment, who is not on treatment. Nevertheless, they all had to have PET scans. That's a positron emission tomography scan. In this case, we're able to confirm both the presence of the insoluble amyloid protein as well as tau protein. So for sure, when someone was randomized in the trial, we knew that they had Alzheimer's. Well, we
Yeah.
had one individual, little older gentleman, qualified for the study, got randomized. Again, I don't know what he had. Now, again, very anecdotal, but he really took a nosedive after starting the study, starting to receive whatever investigational treatment he was randomized to. He got extremely psychotic, extremely
Mm.
agitated, to the point that he very quickly had to drop out of the trial, very quickly ended up in a nursing home where
Oh,
he
sorry.
was behaving extremely, outrageous kind of behaviors. And a neurologist who saw him outside of the context of the trial, decided that he had Lewy body disease. Now,
Yeah.
I don't know on what basis was used to decide
Yeah.
he had that, but perhaps he did, but we know that he also had Alzheimer's without a doubt.
Yep.
And unfortunately, his trajectory was very different than the typical trajectory of Alzheimer's disease. And I recently got notice that he passed away.
Mm.
And probably from the time I met him, he was really just kind of in that mild cognitive impairment stage.
Oh.
And so he declined rapidly in 2 or 3 years to the point of death. So this was a very interesting, presentation.
I'm sorry to hear about that. We have had several people where they presented with, MCI, just as you said, mild cognitive impairment. They went on antibody treatment of one sort or another, whether it was the earlier trials of solanezumab or donanemab, Leqembi, what have you. And with each injection, they would clearly get worse, and then slowly, typically these would be about a month apart. And then I don't know, in your trial, were these 2 weeks apart or a month apart?
They're monthly
Monthly,
infusions.
yeah.
Yeah.
So what they would do is they'd go downhill, and it was typically a couple days, and then they would slowly come almost back to where they were. Then they would get the next injection, and they would go. And the
Mm,
temporal relationship was so striking that, it was hard to say, well, these things are helping them. It really was. We had one guy who went from a 22 on his MoCA down to a 6 over 2 years. And
mm,
I asked the wife, well, weren't you concerned when you saw each month that he was getting worse? And she said, well, the doctors know what they're doing. So, she was going with, okay, this is a trial. And so this worries me. Now, Sally, who I wrote about in the book, and actually who was in the documentary, Memories for Life, Reversing Alzheimer's, which is on Amazon now. And Michael Bublé did a great job with his narration. She talks about, what happened with her. She had, she went through 8 injections, and with each one, she clearly got worse. And so she said after 8 injections, that's enough. She's a nursing professor, so she had taught about Alzheimer's for years, and she said that's enough. And she was going downhill. Now she's done very well, got her MoCA back up to 30, and really made a wonderful comeback. She's now been 7 years on the protocol and
mm,
continuing to do very well. I should mention, Ken, one of the things we found, and we've just posted this. It's in review, so it hasn't been published yet, but it's posted and freely available publicly, which is that we have people who are over 10 years where they've improved and they've maintained it for over 10 years. But
mm,
what we found during that time is people will often have a secondary decline. They'll go for a few years and then they may kind of fall off the wagon. Now, then when you look and say, okay, and in Sally's case, she had after 6 years, she had a
mm,
little bit of decline, and then she was reevaluated by her physician, who found she had undiagnosed sleep apnea, and clearly that should have been picked up, but it was probably worse at that point. The second thing she had was she had new mycotoxin exposure. She had a new leak in her roof, and that was affecting her. And then, interestingly, she had a Cryptococcus laurentii infection, a sinusitis.
mm,
Those 3 things were treated. She went right back up again, did better again. So, I think the overall conceptual model that you are dealing with these insults, and that this is part of the response with the amyloid, with the alpha-synuclein and things like that, is holding up well. The problem, of course, is there is this prionic phenomenon where you're now amplifying the response, just as happens when someone gets DIC in the hospital.
Hmm.
You've got this phenomenon that's kind of a runaway. And so you've got to quell that. You've got to bring that back down. So I think that the different models are kind of coming together. But I think your point about seeing people get worse after these injections, although again, as you said, you didn't know what he was on, but I don't know if the temporal component was there, but what we're seeing, it's very temporally linked.
Well, just to be clear, folks, we're talking about two FDA-approved drugs that had to go through the rigors of clinical trials and convince an FDA advisory panel that this was worthy of being approved and then ultimately approved. But as the expression goes, sort of individual results may vary. And
Yeah,
while the drugs have some modest benefit in general, it's kind of like saying, well, if I take an aspirin every day, does that guarantee that I won't have a stroke or won't have a heart attack or whatever? And of course, many, many people take an aspirin and still have a heart attack or a
yeah,
stroke. So I do want to be cautious. I don't want to leave
right.
people with the impression these treatments don't have any benefit, but clearly we're at the tip of learning and what we can do and what these drugs are really doing. And I hope as we bring on more of this precision medicine and its biomarkers and so forth, we can really say, this is the best treatment for you, but this is the best treatment, for you.
Yeah. I think
In
you,
the
sorry,
Well, in the meantime,
yeah,
Dr. Bredesen,
yeah,
all the things you've alluded to really tell us, let me say that I love this, discussion about antagonistic pleiotrophy and all that, because ultimately when we talk about Parkinson's and Alzheimer's and Lewy body dementia and so forth, it kind of comes back to your infamous 36 holes in the roof. It comes
yeah,
back to saying these diseases sort of start out with common root causes, and then due to biochemical individuality and various other factors, they start to split off, but many
yeah,
still overlap.
yeah,
But it gives us hope that even today, if we can recognize these common root causes, that we can do things about it. And so that kind of goes into the Bredesen protocol. What do people need to understand about the drivers of this disease? Like you mentioned, infection being a major driver.
yeah. That's such a good point. And it brings up the idea that we need to more and more have places where people with any neurodegenerative disease, be it ALS, frontotemporal dementia, Lewy body, Alzheimer's, what have you, a place where anyone can come, like like the Charlin Center that you mentioned, and have these different areas examined to find out, do you have specific infections? And this is where the diagnoses can help us. If it's Alzheimer's, you're going to be thinking more about things like P. gingivalis and herpes simplex and HHV6A and things like that. And on the other hand, of course, what's been associated recently with Parkinson's, this desulfovibrio bacterium, we'll see, whether that is a causal issue, whether that is just an associational issue, we'll see. In ALS, people have looked more at things like Akkermansia and things like that. So the idea then is we need places where people can come. And so I've been working with the Pacific Neuroscience Institute and Dr. David Merrill, Dr. Dan Kelly, very excited about that. And we are setting up a precision brain health program where people with any sort of neurodegenerative condition can come. And as you indicated, infections are important. And I would take it again, look one step farther away. The things that the six major things you mentioned, the 36 holes, and yes, there are all sorts of things that contribute, but the six major groups are, anything that reduces your energetics. And of course, you see that so clearly in Parkinson's, and you see it so clearly in Alzheimer's with reduced blood flow and sleep apnea and things like that. And then anything that increases your inflammation. And that's where what you just mentioned with the various infections, so important. Tick-borne illnesses, exposure to some of the biotoxins that create inflammation. So anything that's creating inflammation increases risk and something that should be addressed. And the third part is toxicity. Anything that is these various biotoxins, inorganics like mercury, air pollution, things like that. And then the organics, things like glyphosate and toluene and benzene and anesthetic agents and things like that. And then the other big three are anything that reduces neurotransmitters. And of course, the classic things that reduce dopamine, increasing your risk for Parkinson's. So the neurotransmitters, and then the neurotrophins, things that reduce BDNF, so much associated with Alzheimer's, which is, you can bring your BDNF with exercise, up with exercise. That really helps in people with some borderline cognitive decline. And then finally, interestingly, stress. And, I have been so impressed with a book that just came out by Dr. Neil Nathan, which is The Sensitive Patient's Guide to Healing.
Mm,
Really, I recommend it because there are so many people, it turns out, that have these changes in limbic response, changes in vagal response, and he has it as a triad, with the third one being the MCAS, being the mast cell activation syndrome. And what's happening is these people have been bombarded by these various insults, and their nervous system has essentially turned off and just said, okay, we cannot handle all this. So we
mm,
are going to limit your ability to respond. And we're going to basically keep you. He describes one patient literally would be walking down the hall and would pass someone who had a certain type of, chemical exposure, for example, because of washing their clothes in a certain detergent. And
mm.
literally the person would fall to the ground. They could
Oh
not
my gosh.
keep their tone because of their vagal issues and limbic issues. And this person got better when he did the appropriate things. But I
Right.
think in all of our practices, we're understanding now more and more that we do have to deal with that part of the problem, that you've got people who are stuck in this stress or threat response. And Dr. D.R. Clausen talks about this a lot with some of his lectures on YouTube and things like that. So I think that these are important pieces, and we're all getting better at understanding, when do we have to address this? When do we have to address that? Allowing us to get better and better outcomes to these people that, as you know, just a few years ago were virtually untreatable. I mean, you look up, there's no effective treatment for Lewy body. Interestingly, on the Mayo Clinic website, it says there's no treatment for PCA, posterior cortical atrophy. Well, we're seeing some improvement in people with PCA. So I think it's a new era, and identifying these things, as you said, infections, so common in these
Mm,
people. And it's typically those chronic infections, but you get exacerbation when people get COVID, when
mm.
people get the flu, when they get acute infections, they get an exacerbation of the underlying problem.
Absolutely. And I couldn't agree with you more about the stress component. So important. We actually interviewed Neil Nathan, Dr. Nathan, for
Good,
this summit. So I
great.
don't know the order of these interviews yet, but folks stay tuned or go back and listen to Dr. Nathan's interview as well. He's an old friend and a wonderful interview. Sometimes in my clinic, when I'm explaining these what really are adaptive responses of the body that don't necessarily serve the person as a whole, I go back to that old scene from Monty Python and the Holy Grail, where the knights are trying to cross the bridge and the gentleman's
Right,
guarding the bridge, and they're sort of, it's slapstick. So, but they're
right,
cutting
right.
him up into pieces, and he keeps saying, "Not dead yet, not dead yet," but until he's a tiny little stump. So
Oh,
yeah, he's not dead yet, but he's lost all function.
yeah,
And learning ways to turn that around by having a system like a Bredesen protocol where we're breaking it down and we're looking at drivers of inflammation and we're looking at drivers of oxidative stress and we're looking at infections and we're looking at glycemic control, which I wanted to bring up because we're still in this epidemic of quote diabesity,
yeah,
and you know I think I have the expression, like you ain't seen nothing yet,
yeah,
because we're not getting ahead of the problem. In fact, I think I'm not a conspiracy theorist, but I almost think that some of the all the excitement over the Ozempic, semaglutide type drugs
Right.
is almost like, well, we got people heavy and now we have a drug to treat them to get them thin. And then the cycle can start all over again. And we just sold you on the junk food and the edible food like substances, borrowing from Michael Pollan. And now we're just going to give you a drug to turn it around. Not that the drugs don't have value. In fact, as you probably know, there was a paper in New England Journal not long ago about the impact on Parkinson's. Dave Perlmutter and I talked about that during his interview. But we would really hope to catch things at a much earlier stage. We can, save people the trouble of these diseases or reverse them when they're still in early stages.
Absolutely. And I think, again, as we get better and better biomarkers and more people to understand that the way to reduce the global burden of neurodegeneration is to get in early, get on active prevention. We recommend that everyone begin active prevention at 40, get evaluated, get a cognoscopy, get on active prevention. And you mentioned earlier about Parkinson's and some of these others. The idea is to take the overall approach that we're all using, looking at these different upstream causes, the various contributors, and then adapt it. When you look at Parkinson's and Lewy body, you have to look more carefully at organic toxins, things like TCE and PCE, and all the different toxins that are associated with Parkinsonism, all that have an impact on mitochondrial complex 1. When you're looking at macular degeneration, you have to look more at inflammatory components and things like complement activation and things like that. You've got to look at how much blue light exposure and things like that. So for each of these conditions, we need to look at and adapt that. What are the things, what are the upstream 36 holes that are actually going to be the most likely problems? And I think doing that, we really should be able to prevent and in many cases reverse people who have these different neurodegenerative conditions, where in the past it's been you wait till it's really late and then you give a medicine which doesn't do very much.
Well, one of the practical aspects of this, Dr. Bredesen, of course, is finding practitioners that understand this and that
Yeah.
can help people implement these principles. And I know that's been a big part of your efforts, is helping to educate folks and really put a network together. So can you provide a little update on that?
Absolutely, yeah. And so people can take Recode 2.0 training. And actually, I look forward to the day when there's optimized training, and maybe this is something you're going to be doing. I don't know, but for how to approach Parkinson's. But for cognitive decline, we have Recode 2.0 training that's available. We've had over 2,000 physicians train and other healthcare professionals as well. Everything from health coaches, neuropsychologists, nurse practitioners, LPNs, RNs, on and on and on. That have trained in this area. And so we've got them, as you said, all over the United States and all over the world. We've got 10 different countries around the world. There are people in Japan and people in France and people in Germany and the UK and on and on and on. And so I think that more and more people will begin to see this. At the same time, as you indicated, the majority of people do not know this. So if you go into a typical university hospital today, people won't be looking for the upstream causes of your neurodegenerative process, unfortunately. And I look forward to an update, and I look forward at some point to the day when that will be the case.
So our mutual friend, Dr. Terry Walls, sometimes talks about the Walls protocol as sort
Yeah,
of the kind of the public health version of functional medicine, meaning
yeah.
Dr. Walls doesn't treat a lot of individual people. She does a lot of research, she does wonderful research publication and so forth. That's really helped all of our efforts. But she'll say, if you need that one-on-one, go see. And, she does send a lot of patients to me. But my point is, if
Mhm.
we were to give folks watching our interview today sort of that public health general principles, where can I start? What can I do just on my own? What can I do that could at least put a dent in this situation? I wonder if you'd share 3 or 4 thoughts about what people can practically do before they necessarily dive into labs and individualized
Yeah.
attention.
Yeah, such a good point because the idea to have a public health a big impact without costing a lot of money. The idea is to have a multi-tiered system. So you start with some basics, and then if people begin to develop symptoms, they go to the next level, and so forth and so on. I think that's going to be the future. I also do think the future is going to be, drugs and protocol together. But what's easiest to do today, I wrote a book on this called the End of Alzheimer's and the End of Alzheimer's Program. Though the End of Alzheimer's Program has more of the basics. Here's the, nuts and bolts, do this, do this, do this. That's the easiest thing to do. And then beyond that, there are some, we always think of this in terms of 7 basics and then specifics. And the specifics you can look at based on your testing. And there are now tests that you can get biomarkers. You can get what we're calling a brain scan, which is p-tau 217 along with GFAP and NFL. So you can do that online through, you get mobile phlebotomy and you can see your result there. But let's go back to the 7 basics, and many of these apply to Lewy body as well and Parkinson's. So it's diet. We typically look at what we call KetoFlex 12-3, which is a plant-rich, mildly ketogenic diet, getting people away from that insulin resistance that you mentioned earlier, that's been such an issue with diabetes. So diet, exercise, sleep, stress, brain training, some detox, and then some targeted supplements. And those are the basics that can help most people, especially early on. The earlier you start, the better. Then the specifics have to do with looking for those infections that you mentioned earlier and looking for those toxins. And when we're looking at Lewy body, we want to tilt this more toward toxicity. There seems to be a lot of toxin associated Lewy body disease. And so we want to look very specifically at the organic toxins, at the biotoxins, and at the inorganic, the metallotoxins and things like that. And we see it again and again. And people have talked about even things like exposure to carbon monoxide and things like that that can increase your risk. So finding out if you have toxin exposure is so important. So people can get started. You can even look at, there's a freely publicly available paper where we talked about the rationale for a precision medicine protocol for cognitive decline. That is freely available online. It's at the Journal of Alzheimer's Disease. And we go through the rationale for the different pieces. So I think that there is a lot now that's publicly available, and people can just look to see, how to get started. And then I always think it's a good idea to work with a health coach at some point, even if it's someone you're not seeing, every day or every week. Someone that can help guide you and kind of get you going in the right direction. I think the health coaches are so important for best outcomes. And then look, if you have symptoms, you want to see a physician like Dr. Charlin or like someone who really has good experience. And I always ask, find someone who can tell you, yes, I have improved symptoms in patients, not just followed them as they went downhill, but I've actually seen people improve their symptoms. With these biomarkers that you were talking about, things like p-tau 217, you can actually now follow to see, is the person going in the right direction?
It is a very exciting time, and our colleague down at Florida Atlantic University reported on a case. And of course,
Right?
again, individual results may vary,
Yeah.
but Dr. Richard Isaacson, who headed up the Alzheimer's Prevention Center at Weill Cornell in Manhattan and now joined his brother Stuart as a Parkinson's expert in Florida. But he had a case where he used the Procivity AD2 test and was
Mhm.
able to track over time that the individual's scores were getting lower and lower, consistent with
Yeah.
the disappearance of these pathological
Great.
proteins.
So great to
It's
see.
it is. It's wonderful for all of us, and it's really not just tip of the hat to Dr. Isaacson, but also to show that, we truly are in the age of biomarkers. And as you probably know, the Alzheimer's Association just released their most updated position paper, basically going through what are the diagnostic
Yeah,
criteria. And really going back since about 2013, they started to embrace these biomarkers. And there's been little shifts, but to my knowledge, the most significant change in the 2024 criteria is that they have embraced the blood biomarkers now,
right.
uh, the p-tau 217 and all that. So, folks, I want you to understand that, you know, I think I can speak for Dr. Bredesen to say that we want this information to be available to everyone. We don't want this information to be just for sort of the rich, the elite, or whatever, those who can afford it. We want, yes, there are things that can be a little more time, a little more demanding, and a little more demanding of professional, expertise, and those things can raise sort of the price tag of the service that's provided or the cost of the test. But that being said, there are things that you can do at every stage, at every level, and even Medicare has their cognitive assessment CPT code 9924 9283, I think it is. But at any rate, that technically allows the practitioner to run a panel of blood work and to sit down with you as a patient and really go through not only what are the findings, but a cognitive care plan that allows the physician to be reimbursed for those services. Now, is it the Bredesen protocol? Is it the Charlene protocol? Probably not quite as detailed, but it is of value nevertheless. We just need more practitioners that know that that code is out there and then have the toolbox to actually show the patients what to do and then to help them implement that, maybe with a health coach, an excellent choice.
Yeah, that's a great point. One of the things that's exciting is with these biomarkers, you can actually see, just as you said with Dr. Isaacson's patient, you're literally seeing that the person had underlying Alzheimer's. They just didn't have much in the way of symptoms yet. But now you're seeing the biomarker showing that this process, this ongoing pathophysiological process, is now going down and is no longer in the range. As he pointed out, it gets to the point where it's no longer in the range you associate with Alzheimer's disease. So that you had something off long before. It's almost like, seeing something way down the road and preventing an accident.
Mm.
I think these are going to be valuable, and I think we'll also get more information seeing what has actually helped, what actually moved the needle, what didn't move the needle, that sort of thing. So that's very exciting. We should get to a place where neurodegenerative symptoms are relatively rare, that people get this picked up, just as you'd have your blood pressure checked, just as you'd have your cholesterol checked, those sorts of things. You will have these markers checked and you say, okay, you were going to get Alzheimer's 15 or 20 years from now, or Parkinson's, or Lewy body. But now we're going to make sure that you never get that. And I think that's going to change
Oh,
things
it's wonderful.
dramatically.
It's definitely, and this is a lovely way to even circle back around to the anti-amyloid therapy that we started talking about. Not that
Yeah.
I'm telling everyone to go out and do that, but when we look at the data, the way that the donanemab trial was structured, and when they looked at the subset of individuals who just had mild cognitive impairment but didn't meet full clinical criteria for Alzheimer's, their outcomes were twice as good as the people who are already in that Alzheimer's stage. Does that mean that the treatment is the right treatment for you? Not necessarily, but what it says, to Dr. Bredesen's point, is that
Yeah.
early intervention is key. Early intervention with diet, with sleep, with movement, with a stress resilience practice, with identifying and eliminating toxins, including infections, as well as heavy metals and other chemicals, cleaning up your environment, cleaning up your body, getting rid of this stuff makes the biggest difference is made when we catch this early.
Absolutely. Yeah, and I look forward to the day when there's just a simple neurodegenerative panel where, and I know there are some neurodegenerative panels now, but I'm talking about one that would be the earliest changes,
Mm.
would probably include a sweat related mass spec test,
Mm.
which can be done fairly quickly. It would probably include p-tau 217. It would probably include, markers for ALS as well, that sort of thing, and say, okay, you have a clean bill of health. You're not headed for any neurodegenerative conditions down the road. Or someone say, oh, yeah, you were actually headed for Parkinson's, but we're not
Mm.
going to let you get there symptomatically. This will really change healthcare.
I think it will happen. We're
Yeah,
starting to see evidence of that already. So it's a very exciting time. I hope we all live long enough to see it come to full fruition.
I do as
Well,
well.
Dr. Dale Bredesen, thank you so much for being part of the Parkinson's Solutions Summit 2.0. I know people are very excited about your protocol. Have many patients who come to see me who've either already read your books or watched you online or maybe had the opportunity to hear you speak in person. If folks do want to get involved with Apollo and your protocol and what should they do? What should they
Yeah,
do?
thanks for asking, Ken. So lots of ways. So you can go to mycognoscopy.com. So that'll look at the testing and how to get those. Then there's getabrainscan.com, which is this is to give you the p-tau. The most sensitive p-tau is through that group, and that's through a company called Neurocode. They have currently the most sensitive p-tau, NFL, and GFAP. You can go to looking at one of the books. There's the End of Alzheimer's, the End of Alzheimer's program, and the First Survivors of Alzheimer's. You can look on Facebook, Dr. Dale Bredesen. Same for Instagram, same for Twitter. So any of those social networks, looking, I guess now Twitter now called X, any of those networks to get more information. And you can look at our published papers. We have many published papers that we published over 230 papers, and a number of these are available publicly, freely available online. So lots of ways to get additional information. And I encourage everyone, be active if you are 40 years of age or older, and especially if there's any history of Parkinson's or Lewy body or Alzheimer's in your family. Get evaluated, get a cognoscopy, or see an expert like Dr. Charlin. Get evaluated so that we can have a world that has less neurodegenerative disease. It has been a huge, huge problem, as you know.
Well, thank you so much. Look forward to seeing you soon. I think by the time this airs, it will be past, but I think hopefully we're going to see each other this coming October in Washington, D.C. So I
Fantastic.
think you're scheduled to speak as well as myself.
Great.
Have a
All right.
wonderful
Thanks,
rest of
Ken.
your day, Dr. Bredesen.
You too. Take care. Thanks. Bye-bye.